Hi, Amrita. Thank you for joining us today. Today we are discussing about the health system
Hmm.
and your big idea regarding the health system. Um, and I'll start with, I think, the most fundamental question here. What is it that you define as a health system?
Yeah, I'm happy to share my views on health system and what is a health system. Um, we all think about health as doctors and medicines and tests and hospitals and increasingly insurance and doctors and nurses. All of these are components of the health segment and sector. However, I would define system as one which is interlinkages and which we can use the interlinkages to drive health outcomes and quality of care and efficiency improvement. Standalone, these components are just components. They do not drive the changes, they do not drive improvements.
Right.
So the system as a whole, where all of these parameters and things which are outside the health sector, which is traditional health sector, are also part of the health system. For example, clean water, clean air, all of these come together to create health outcomes. So that's what I would say is health system.
I think you touch upon a very important point that there are elements outside of what we call traditional healthcare
Yeah.
or health system that are important to consider as part of the health system. So, what, according to you, are the critical elements of the system?
So I would think there are three main elements of the system. One is what causes diseases. So this is clean air, clean water, parks to exercise, good access to sunlight, crowded homes, avoiding crowded homes, things like that. So I would call them goods, public goods for healthcare or health, I would say. The second thing I would say is what drives efficiency within the health system. So you've fallen ill, and you've started having some symptoms. So, what can really improve the market failure and improve the efficiency of what healthcare you get? So, this is early primary care. This is also a lot of what other countries have done is improving the health financing system. So, the payer provider split and the payer and the patient split, and the provider payer being separate, and then overseeing the interaction between the patient and the provider, and therefore overcoming the information asymmetry through
Right.
specialized capability building is one way to do that efficiency building. That's the second component. There are many elements to sub elements to this. The third element is how do you disrupt the quality cost curve completely?
Right.
So, which is not around efficiencies on the margin, but completely. When we discovered COVID vaccine, it was a step jump
Right.
into how we could live our lives, right? It was a disproportionate impact on what we were doing. Similarly, when we discovered penicillin, it
Right.
was a step jump into what was happening. Or when we are discovering how to do angioplasty.
Right.
So, these is what I would call disruptive innovations, and that's the third leg of the health system.
Okay. I think then the subsequent question is we understand that there's something going amiss within the system.
Hmm.
I think as a regular consumer human being, I
Yeah,
understand the
yeah.
system necessarily isn't working the way
Hmm.
it's supposed to. So I think the question then is why is it not working? What is it holding back?
There are several challenges. When you talk to people who work in the health space, they will enumerate a long list of health challenges which exist, system challenges, financing challenges. When I step back and I look at what are the critical things which are really resulting in those challenges to exist, I would say in my mind there are twofold. Uh, One is knowledge in the context of that country or that location, how these systems interact with each other and therefore result in health outcomes. Um, Often it is seen in silos,
Right.
and the context of every country differs. What happens in UK cannot happen in India,
Yeah.
and we often tend to pay port knowledge from, right now, and UK is always a favorite. Thailand is another favorite among health system practitioners,
Right.
and they will port, but that will not work in India
Right.
because we do not have the same three components of the health system. The second thing I would say is the governance.
Right.
Um, each of these parts have fragmented governance
Right.
where everybody sees their own piece. So, Ministry of Health will see within the second bucket of efficiency improvement, they will see the efficiency of their service delivery. The private sector is doing its own thing. Insurance regulator will do its own thing. There's no common regulator for all the public goods, clean
Right.
air, clean water. There's no government capacity for that. So the example I would give is local governance is very critical for clean air, clean water,
Yeah.
and local bodies are not really strong in India.
Yeah.
So since there's governance weakness at all levels, and there's no overarching mandate or view of the governance entities. Therefore, we do piecemeal efforts within each of these systems, and we do not reach our efforts.
I think it's interesting, especially when you talk about the fact that at the local level also things like households, how much clean water they're getting, or the way the environment is around those households. These are local level, district level efforts. And I do understand that because of that not happening, households then are more prone to diseases in certain parts. So in terms of just thinking about how do you then improve this efficiency, because again, system needs to improve, we have understood it's been held back. So what are the different ways in terms of improving this efficiency across the different systems?
Yes, the good part is a lot of improvement is happening on its own. So slowly and steadily, good practices, scientific knowledge, or ancient historic knowledge on fasting and things like that. So there's things which individuals can do, and I think individuals are becoming more and more aware. There are things which with I think the states and the local level bodies can do.
Yeah.
So I would start when I have thought about this problem statement because it's complex. And how do you get all governance entities to work well together? It is an impossible hope. So I think where we should really start is at one good local body or one state.
Right.
And then we hope to sort of create sample examples of how to really go about it in the Indian context. So if state of municipality of Bombay has a lot of money, and we can hope to build public capabilities within it.
Right.
And then it's for researchers and practitioners to really work with them to sort of understand how do you really create that from a health perspective,
Right.
not from a infrastructure delivery perspective, what a municipality would do. And then we take those learnings and we port them to other municipalities. Obviously, they will have to be financial ability building and capability governance building for many municipalities. So it is not really a health issue, it's also a multiple sector issue. And then we'll have to port it. We also have in many states a very good starting point on, say, health financing, where we have secondary and tertiary care, insurance, government sponsored insurance schemes, which are very large.
Right.
But what there's an issue with that, they have an implicit package. So what they do is they promise, say, 1,300 or 1,500 packages, health packages to be delivered. But what happens? You have a little bit of money, you diffuse them in too many things, and you don't get the bang for the buck.
No.
So if you do something like an explicit smaller package, so Chile's or example is fantastic.
Right.
So they took a very large package where they were not getting any bang for the buck. They created a smaller package out of it while retaining the larger package, and they disproportionately put their efforts into improving financing, payments, clinical protocols, outcomes for those 50 most important things which they considered for the country. And then they also added a step ladder. So yes, great, poor can pay for them, cannot pay, you pay for themselves, you can pay for them. For the middle income, why should the government subsidize? So then you have a step ladder where partially the middle income starts contributing.
Right.
And then you create the benefits package as such that the middle income has incentives to graduate and self-pay.
Right.
So it's a very interesting model which has happened in other countries. How to create a step ladder so that scarce public resources can be efficiently used while also organizing the out-of-pocket market.
Right. I think that's a very interesting thing that you've mentioned. And it sort of is a full circle moment for me, because I think that a lot of what you're saying is that there's a need for cross-disciplinary, or as XKDR refers to, the X in addressing these market failures in the system. And I suppose the real question is, how can we use the different participants, different stakeholders, and use them collaboratively to achieve a certain goal?
Yeah. Absolutely. I think that's the direction we need to go towards.
Yeah. Thank you so much. It's been lovely speaking to you on this, and hopefully this big idea delivers pretty soon.
Lovely to be here.